Good afternoon, everyone. Welcome, especially to today's section. Good to have you. It's a pleasure to have you here today. My name is Chiamaka Obina, and today's section we'll be looking at healthcare waste management program, case study FMC Ebute Metta Lagos, and our speaker will be Dr. Usman Olagoke. Before I introduce him, I would love to say that healthcare waste management remains a critical component of IPC, yet it's often an area where many facilities face challenges, unfortunately. Poor handling of healthcare waste poses risk not only to healthcare workers and patients, but also to our environment and also our wider community. And so in this section, we will take a practical look at how a facility, FMC Ebute Metta, has approached this challenge. Through their case study, we explore existing gaps, the innovative solutions being adopted, and also the lessons learned in implementing safer and more sustainable waste management practices. Our discussions today, we highlight some of the strategies that we can use to improve compliance, reduce risk, and also strengthen IPC outcomes. So today we're looking forward to having a very engaging section. I also expect that some of us will make contributions, ask the necessary questions, and also be able to take away practical insights and actionable ideas that can be applied to our own facilities. To take us through today's section is no other person than our amiable Dr. Usman Olagoke. He has been part of the success story of transforming Federal Medical Center Ebute Metta to a model healthcare facility in the country. As the head of quality improvement and infection control of the institution, him and his team propelled the hospital to attain a 4-star rating in 2021 by Safe Care, an organization that is accredited by the International Society for Quality in Healthcare External Evaluation Association, that's IEEA. Dr. Olagoke Usman is a graduate of University of Ilorin and a fellow of West African College of Physicians, Faculty of Family Medicine. He also bagged a diploma in Infection Prevention Control, College of Medicine, University of Lagos. He's a very senior consultant special grade 1, and a trainer of resident doctors at the Federal Medical Center, Ebute Metta, Lagos. He's currently the hospital IPC focal person and the HOD, Department of Quality Improvement and Infection Control. Such a very robust CV. Please, let's do well to welcome our speaker. We can use our emojis in the chat to welcome him. Dr. Olagoke, it's a pleasure to have you here. Thank you for your willingness to share your time and expertise. And I want to believe that a lot of us are looking forward to this interesting section today. Welcome, Dr. Usman. Let me share your slide now.
Thank you, Chiamaka. I'm delighted to be here. I want to welcome all participants to this IECO session being hosted by Nigerian Society of Infection Control. And like Chiamaka had rightly introduced the subject, we are looking at healthcare waste management. And without wasting much of our time, because we still have a lot of things to do, the outline of my presentation looks like this. I will introduce the topic, briefly talk about healthcare waste management, because what we are trying to discuss is how to improve it. So because we are using Federal Medical Center Ebute Metta as a case study, I want to give a brief description of this hospital so that we can understand the magnitude of the challenges we are facing and how we try to rectify it. We'll also talk about healthcare waste management before and the improvement approach and what it looks now, the challenges we are facing, the ones we faced and the one we are still facing, and then I will conclude. Good. So, talking about healthcare management, Chamaka rightly said the other time that is all our healthcare waste, the ones we generated in our health facilities, as opposed to the domestic waste, which are also equally important. These wastes are potentially harmful because they contain some microorganisms that can infect our patients, even the healthcare workers, the patient's relatives, and everybody in the hospital environment. So it's very important that we manage those wastes properly. And there are two major categories of healthcare waste, the hazardous waste and non-hazardous waste. The non-hazardous waste can be categorized as general waste, which are similar to our domestic waste, but we are talking about healthcare facilities. So we also generate some of these waste in our healthcare facilities. The difference between that is that some of these waste, as simple as they are, they also contain some of the microorganisms from the patient's flora, from our own flora, and then want to break the transmission of infection in the hospital. So we need to take care of all this general waste. The hazardous waste, these are just the hazardous waste. Sharps will agree with me, it's hazardous. So most of these hazardous waste are infectious. Some are hazardous, but not infectious, because when we talk about radioactive materials, they are hazardous to our health, but not necessarily infectious. So we still need to manage them. Same thing for chemical waste, pharmaceutical waste. The pathological waste and infectious waste, the pathological waste, we can say they are highly infectious because they are the ones that are heavily soaked with body fluids, human tissues, placentas, and everything that is removed, especially during surgical procedure. The infectious waste, as we go on, we'll understand what the contents are. Now, so I want to take us to the steps in healthcare waste management, because we need to understand the steps to give us full understanding of the healthcare waste that we have, how we handle it, how we manage it, from the point of generation to the point of disposal. The steps are actually described as from cradle to grave. I mean, the cradle is when you generate the waste, and the grave is the final disposal. Okay, so waste minimization is the first steps in managing waste. When we talk about waste minimization, we are actually talking about how you reduce waste. I mean, the generation of waste, how you contain it so that you don't generate too much waste. Minimize the waste that you generate. And there are many ways of doing that. For instance, if we promote oral medication as opposed to injectables, you will realize that we are reducing the amount of injections that we are giving to our patients, and such reducing the risk involved with injections, such as needle pricks and all whatnot. So those are steps of minimizing waste. We can also reduce all our expiries if we tailor our procurement based on forecasting. We will not be buying too much of these hospital materials such that at the end of the day they expired and then we have to dispose of them. We also need to reduce unnecessary and inappropriate use of our PPEs and disposable. You agree with me? Where you are not supposed to wear gloves, don't wear. And if you are supposed to wear gloves, wear only one, not two, not three. So if you do that, you are minimizing waste. The next step is about segregating the waste, that is separating the hazardous from non-hazardous, the hazardous ones separating the infectious from the non-infectious, the highly infectious, ones, you separate them such that they can be handled differently and disposed of differently. The waste collection is about collecting all this waste from where they have been dumped, either temporarily to a temporary storage site, on site, that is within the facility, before they are being taken to a more permanent storage site, which can also be on site within the facility or outside the facility, which we call off-site. Transportation, like the name implies, is how we transport this facility to the storage site and then to the final area where it is going to be disposed. We need to know how we transport all this waste. The treatment, waste treatment to reduce their infectivity and the likes, and then the final disposal. Your disposal can be on-site, it can be off-site. If we have the facility to dispose of your waste, you can dispose them on-site. So that's brief enough to let us know how we manage waste, the steps in managing the waste. So we are looking at Federal Medical Center Ebute Metta as our case study. We used to be a 200-bedded hospital. Now, because of the expansion and the development that have happened in the last couple of years, we have more than 400 beds and still counting. So you realize that we are progressing from, or we are transmitting from generating certain small amount of waste to now generating larger amounts of waste, because the more you develop, the more waste that you produce, you generate, because you now have more patients, you now have more staff, you now have more equipment and everything. So your generation of waste will increase, and you need to keep up with the pace of managing. Purposely put that to let we have a small, because we are just like a visitor or a stranger, or what do you call it, within somebody's territory. So if we cannot expand laterally, we can expand vertically. We need to put that in case, because sometimes you need to put some structures in the hospital, but there is no space for you to put it. So we have to manage what we have to get the best results that we want to achieve. We have catchment areas both in Lagos and outside of Lagos. In fact, recent developments, the other sister tertiary hospitals who are far from our big brothers and sisters, patients are not even going there. They are actually coming to Federal Medical Center Ebute Metta. Everybody wants to access healthcare at the Federal Medical Center Ebute Metta. We are serving island areas in Lagos and the mainland, because we are strategically placed at the mainland, like a border between land and island. And we have a lot of ports surrounding us, the Apapa ports, the railway, the airports, and you must know the significance of that, because when people are coming in to Lagos or from to Nigeria, these are their first point of call. So these are the services we render. We render outpatient services like any other tertiary hospital, inpatient, surgical specialties, most of the surgical specialties, medical, obs and gyn, intensive care unit, emergency, laboratory, radiodiagnosis, oncology, and all whatnot. So you can have an idea of the kind of waste that we'll be generating. Luckily, FMC Ebute Metta has an IPC program. We have an IPC committee, we have a team, and we have our link nurses who are the ears and our eyes in their various units, the wards and the clinic. We also have our policies, especially the healthcare waste policy. So it is very important that you have an IPC program, somebody to be championing all this infection control program and be part of the people that manage waste in your hospital. Waste in the hospital is primarily saddled with the environmental health department, where we work together. And in fact, the HOD, the present HOD of that department in my hospital, is a member of my IPC team. She was just a member of the department at the onset of our IPC program. Now she had risen to become the head of department. It's a plus for us because the communication is so smooth and so understanding between us. So before now, at the Federal Medical Center, Ebute Metta, what we used to have are commingling of waste. You see, we make waste together, whether it's a general waste, whether it is infectious waste, we just dump everything in one place. And you remember we were talking about we're not segregating our waste. Then all our bins are not appropriately placed. In fact, some of them are like environmental eyesores. You have them being put where they are not supposed to be. Our sharp boxes are on the floor in areas. You'll see some of these pictures. Our waste are overflowing. Our bins are not covered. And our dump sites, people in Lagos, we appreciate the description of our dump sites where you have a large trough placed somewhere at the corner at the outskirts of the hospital, and people drop all sorts of things there. Even the residents in the railway compound come and drop things, and it's flowing before we have people to come and take them away. These are some of the things that you see. Now, we have an MOU with LOMA. LOMA is Lagos Waste Management Authority. They are the ones from onset that will come and pick up all our waste. The ones that
Dr. Usman, please confirm that you're still there. Okay, I think he's been disconnected.
okay, so I think I went off.
Yes, welcome back.
It's the network. Maybe I should just off the video. I think I'm having, my network is so slow.
Okay.
Anyways, so I'm actually talking about our Memorandum of Understanding with Lagos Waste Management Authority. They come and pack our waste, and then they also have a section to collect our histopathological waste. That's talking about waste that are generated from organs and tissues from the histopath laboratory. Suffice it to say that then all other waste that are actually highly infectious were dumped together in that waste trough that I talked about before the LOMA compactor comes to pick it up. All right. So, having painted some of these scenarios briefly, because it's actually more than this, I don't want to scare us of what we were doing before, because most of you are here. We have been here at the Federal Medical Center, Ebute Metta, when it was rosy, when it is actually rosy, and you wouldn't know what we're facing before we reach this stage. So, but before we reach this stage, we actually do what we call healthcare waste management improvements. You know, any IPC improvements that you want to do, you have been enjoying to take the multimodal strategy. Then when we were trying to improve, we didn't know anything about multimodal strategy, but now looking back, we were actually doing multimodal strategy, not unknowingly. So what multimodal strategy, let's run through it. System change is about infrastructures, making sure the infrastructures are in place for waste management. We are talking about the bins and every other thing that you need for proper waste management. Training and education, you need to train your staff on how to properly dispose of waste, minimize waste, segregate waste, and the disposer. The health assistants as well as the environmental health workers that handle the waste must be properly trained. Then you need to keep monitoring these waste management efforts. You evaluate from time to time and give feedback to units and to the management. And of course, we place, you have to place workplace reminders, posters, and other things to show people that you are actually doing safer waste management in FMC Ebute Metta. Okay. Safety climate is about institutionalizing this waste management thing by making it our culture. You say the same way you wake up in the morning and you just go and brush your mouth, take your bath, and eat. Nobody tells you to do those things. It has become part and parcel of you. That's the same way we want healthcare waste management to be. And we are sure we are going to be there, making it our culture such that automatically, if you want to dispose of waste, you're actually looking for the appropriate place to dispose of it, not just anywhere. And to do this, we need a stepwise approach, which is, of course, a continuous cycle of improvements, whereby you prepare for action, you do a baseline assessment, you develop an action, you evaluate the impacts, and from the evaluation, if you see any other gap, you go back to it again, address the gap by preparing for action, doing baseline, phase of intervention now, because you have identified a gap and you want to intervene, you develop an action, you evaluate it again, and you keep on like that until you get it sorted out. So these are the things we did. When we're planning for we need to do and actually put some people to be responsible for each task. And most importantly, you have to give timelines, because you don't just give somebody and say, okay, you go and find out about something, and then you don't give a timeline for that person. The tendency is that the person will forget, or we take it for granted, and then the assignment will not be done. Timeline is very important. And then you come back again to meet to review your progress. Essentially, that was what we were doing then. And we did our baseline. Our baseline, we did knowledge and attitude and practice of healthcare workers, including patients, in the environment. How did they hear about healthcare waste? Are they aware of the risk involved? All of these things we did. And then we try and look for the infrastructural needs that we require to actually bring about proper healthcare waste management. And, I said that is the first thing you need to do under multimodal approach. That's making sure that the infrastructures are there. If they are not there, what will you be preaching and what will you be talking about? If you ask people to dump their waste in so place and there is nothing, there is no bin, there is no appropriate bin for them to dump such way. So I stumbled on this in my file. It may not be clear where that's a table that we drew for ourselves to actually look for what our infrastructural needs. We were talking about sharp box and waste bin, and we went around the hospital noting that for each unit, This is the amount of sharp boxes that we'll need, and this is the amount of the waste bin that we'll need. From there, we were able to have an idea of what to sell to management, because there will be a lot of procurement and we need to sell a lot of things to management. So if you are trying to improve, you need to find out what are your infrastructural needs. Do you have waste bin in place? In FMC Ebute Metta, we are adopting the color coding bins, the black, yellow, and red, and then the sharp boxes too. Those are the things we're doing. Presently, we are developing our oncology center, so we'll have to improve on that as well, because very soon our irradiation aspect of that oncology center will come on board, and we'll have to be thinking about how to manage the waste associated with that. So we developed our action plans. We did an advocacy drive to stakeholders, especially our nurses, because they are the ones that spend more time with the patients, and waste are generated on their wards and clinics. It's like every other healthcare workers, we just visit and leave, but they stay in those units. So you need to do an advocacy drive to people that matters, people that will accept your program, do like a lot of campaign and education and discuss around identify the ones that are powerful and the ones that are influential, those that will speak to other people. And this also includes the unions. We need to speak with our union bodies such that they can carry the messages to their when I say management, the head of your facility, the management committee of your facility, whether it's the CMD and his co-management committee members, or the medical director, as the case may be, because they are going to be heavily involved in terms of making sure that the infrastructures that you need are actually available. For us in FMC Ebute Metta, we're lucky to have a medical director that is very, very on the know-how, very much on the know-how of the importance of IPC and as well as healthcare waste management. So we were lucky, as you are selling the ideas to him, he's always buying. You must be able to convince him. It's not as if that you just go and then talk and then he does something. No, you have to convince him about what you're actually doing. Then you draw up a policy and guidelines for your healthcare waste management. What do you want to do? You know, I said for us in FMC Ebute Metta, I wanted to be doing color coding, the red, yellow, and black. Now we have to go back to include the radiation waste as well. So you need your policy and guidelines, because those guidelines are the things you use to train the people you want to train. And part of what to do is train and educate your staff. Train your IPC team, train your staff, clinical staff, non-clinical staff, and occasionally when you come into contact with your patients, you train them as well. You educate them about waste disposal, especially when they gather in the waiting hall, either at the outpatient clinic or the inpatient clinics. When they are actually waiting, you talk to them. You have waste bins surrounding you, mostly general waste bins. These are places where you don't just drop it on the floor and all those things. So we were able to do that, and we're able to procure PIDA waste bins, the small one and the medium one. And one challenge here is that while procuring the bins, we would have loved to have bins with the red, yellow, and black color. But of course, before we can do that, we have to enter MOU with a manufacturing company, which we are not privileged to do. So we just gather any PIDA waste bin that is of the size that we require. What we did to identify those things is the lining we put inside, the yellow lining, the red lining, and the black lining. And then we put posters on top of the lead bin to indicate what kind of waste you trash into those bins. We also have media ones outside the clinical areas. Those are the ones you are seeing on the left of your screen, such that when these ones in the clinical areas are filled, they are taken to the smaller ones. It is the environmental waste handlers that will now come to pick this one to the bigger ones, which are actually the wheeler bins in the next slide. So the next slide is actually showing you the wheeler bins that the environmental health workers will use to take to our secured storage sites. So we also have our sharp boxes, and then because of the training that our people have received, and with the help of our link nurses, our sharp boxes that are always on the floor are now off the floor, because our sharp boxes are actually carton, which if it becomes damp can be weakened, and then some of those sharps can be protruding from them and cause some injuries. That's the reason we want it off the floor. And even when it is off the floor, there is tendency for somebody to just kick it and then spill a lot of things that the contents outside. So they are not overfilled anymore, and they are on the trolley, the treatment trolley, and if they are not in the treatment trolley, they are hanged somewhere. This one we are seeing is very low. We are actually trying to we are trying to make it higher. So part of the system change we're able to achieve is a secured storage site. Your storage site must be secured, must be under lock and key, must be well ventilated, and should be able to prevent human and animal scavengers, people that will come and pick up things that they think they still need from your waste. So it is from this secure storage site that Loma compactor will come and pick some of these things. You can see we were able to get a small incinerator ourselves, which is, of course, is no longer serving us well because it's small, and then we are generating more waste. If you can see behind that incinerator, we still have a lot of waste waiting to be incinerated, because if you pack the chambers too much, there will be the kind of burning that will take place will be incomplete, and the emission will be too much for us to bear. So we have to be doing it slowly. This is one of the challenges that we are trying to sort now. Okay. Then your secured area must have all these signs that unauthorized people cannot enter that place. It's only our environmental health waste managers that actually have the keys to the area. If you draw it closer, you will see that the key is actually from the inside, because we realize that once it is outside, people picking PET bottles, they break open the key and then go and pick the PET bottle. So it's now inside. They will still break it, but it's going to be difficult for them to do from the inside. So we trained our staff on healthcare waste management, on various aspects of healthcare waste management, what to put in which bins. These are some of the training sessions that we have. You can see in the next slide, one of my team members trying to fold the cartons for sharp boxes, and you can see the linings on the table in the second table where we demonstrate the color coding to our staff. Okay? So we did not stop at that. We monitor, evaluate, and give feedbacks to units. Twice in a week, going around the hospital looking for a lot of things that are deficient or not properly managed, including healthcare waste management. So once we see something, we give immediate feedback. We also write reports. Periodically, we send the reports to the management so that they know what is actually going on. During those rounds, in the next slide, you'll see some of the things we look at when we're doing rounds, especially to waste management. There are other items on this list, on this checklist. I just try to focus on the ones we do on waste. We want to know the number of waste bins. Out of this number, how many are damaged? Because once your waste bin is damaged, you need to repair or replace. And the ones with intersticker, once the stickers are worn out, you need to replace them. And then the linings. Sometimes we are faced with the health assistant, you see them lining a bin with yellow lining, and then the covering there is indicating general waste. We note all these things and give feedback, make corrections. You continue to do this until it becomes a culture, part of us, to know where to put things. We want to know whether the weight bins are overfilled, whether the sharp boxes are on the floor, are they overfilled, and all those things. These are the things that we do during our rounds. These are workplace reminders. Like I said, these are the posters that we put on top of the bins to indicate where, what to put inside that bin. If you look at the spelling of waste in the sticker, is red. That means the lining will be red, and then you put highly infectious waste inside that. If it is black, it is general waste. If it is yellow, it is infectious waste, and the lining will be there appropriately. We also have some signages around saying that you should keep our environment clean by using the waste bin. So we actually have a lot of challenges then and now. And the number one challenge, you will agree with me, is attitudinal change. To change people's behavior is very, very difficult, but we will not stop at that. I will continue to hammer it. One of the ways we are trying to use to change our people's behavior, because somebody said in one behavioral theory which uses the principle of social proof, that is, you view behavior as correct to the degree of what you see others performing. So others performing it, by the time you see somebody who is highly pleased, a management committee member, and your bosses in your units, the directors, the very senior health workers, doing this thing, we encourage them to do these things in the presence of their subordinates so that it will stick and say, okay, what I'm trying to say is that we need to have champions of IPC programs, hand-hygiene champions, waste management champions, and the likes. Now, another challenge is cost of maintenance. Once your bins are damaged beyond repair, you need to replace them. All these things cost money. Now, the present economy is not laughing, in quotes. The present economy of the country is making all of these things difficult. So one of the things we are doing is to retrain, especially our health assistants, in handling those waste bins, because most of them got damaged in the process of handling it, trying to clean it, and some of the users as well. It's pedal-operated bins. Some will just slam their feet on the pedal, and of course it got dislodged. Sometimes it breaks because these things are plastics. We decided to use plastic as against metal such that it will facilitate proper cleaning and disinfection. So staff attrition in this era of Japa, for those who are not in Nigeria, Japa means people going to look for greener pastures elsewhere. Medical staff are actually moving in droves to other countries to look for source of living, or what they say, greener pastures. You say that when you train some people on these things we are talking about, before you know it, they are gone. They are being replaced by newer ones. As you are planning to train the newly employed staff, you realize that half of them have also traveled. That's the situation we find ourselves in. And then the personnel aspect, especially in the environmental health department, that are battling with not having enough personnel, we are making efforts jointly to present the issue to the management so that you can have personnel to do a lot of things that we are not doing before. For instance, we are trying to quantify our waste to know how much waste are we generating in the whole hospital, in different sections of the hospital and the like. It will help us in planning. For instance, in the last administration, we wanted a bigger incinerator, but we need to convince the management why we want a bigger incinerator. These are some of the data we need to give to the management. All we could produce was our storage site filled with awaiting waste to be disposed, to be incinerated. So we are still on that, and we hope that we will get there. Then the training needs, like I said, during staff attrition, you want to train some of your staff, and then you train them, before you know it, they are gone. Our link nurses, before you know it, some of them are retiring, some of them are going for greener pastures, some of them are transferring their services to elsewhere. So we need to be getting others too, and then train them. And it's not easy in terms of cost and energy to train some of these people. Is a challenge which we are trying to overcome. Now, because of the expansion of the hospital, you now see that we need a bigger incinerator. I've talked about that. And one of the challenges we have is LOMA schedules. What I mean by LOMA schedules, for those just joining us, LOMA is Lagos Waste Management Authority that we collaborate with to take care of our waste. And their schedule, the compactor is supposed to come twice in a week. Even this twice in a week, sometimes it's not regular. Either the compactor is faulty or something happened and they are not able to come. Even if they come twice in a week, from the last time they come to the second time they will come in a week, you will see that we will have generated a lot of waste because the hospital is actually growing. So we need to go back and do this MOU again. We are trying to speak with our management to make sure that LOMA should come probably every day or every other day to collect our general waste and the pathological waste as well. So I think I should conclude. Any other thing that I've not been able to say will be discussed or talked about during question and answer. You will agree with me that we have talked about improving our healthcare waste management by adopting this multimodal approach, talking about system change, making sure that the infrastructures are available, and then you train yourself, you do waste segregation, evaluate all the processes and give feedback, and most importantly, you need to collaborate with the community or the local government and the waste collector in your area. For us, we are collaborating with Lagos Waste Management Agency to take care of our general waste, and that is taking them away from our storage sites for the final disposal. And the last word here is that I want us to read this and let it sink. Improving healthcare waste management is not just about ticking boxes. It is about protecting lives, preserving the environment, and enhancing the credibility of health institutions. Thank you very much for listening.
Thank you. Thank you. I was trying to unmute my mic. Thank you so much. Please let's appreciate our speaker. Thank you, Dr. Usman. We really appreciate the time that you have taken out of your very busy schedule to share your knowledge, expertise, and also wealth of experience with us. Please, can we appreciate him using the emojis in the chat? Very wonderful presentation. Thank you so much. Thank you so much. Someone is saying, thank you for the presentation and work in FMC, Ebute, Metta. So let's also have the questions. He's here to take all the questions. For some of us who want to replicate some of the things that he has mentioned today, please, you can engage him with your questions. Someone said placement of the safety buses should be within arm's reach so as to ensure that they are not higher than can be reached by the average worker. Okay, that's a good one. That's a good one. Within reach of for some of us who might not be able to stretch out our arms enough to get to where the box is. So they should be within arm's range. That's great. Thank you. So please, I look forward to having the questions here. While we're putting together our questions, Dr. Usman, I remember when you mentioned, when you were talking about waste minimization, you said that instead of using one glove, that some people use 2 or 3. I don't know if it's because they do not trust the gloves. We know that there are situations where people don't trust the gloves. Maybe there are punctures also, just to ensure that they're adequately protected. You see some people using 2, 3 at a time. What do you have to say about that? Or is it that those gloves are properly, they are very, very good and one can trust it enough to just use one glove?
Well, you said part of it is the issue of trust, but more importantly is the issue of fear. In fact, when you are not supposed to use glove, out of fear and trust, like you said, people tend to use gloves for procedures, for activities that doesn't need gloves. And then for some procedure that you need gloves, probably out of trust, but more importantly, out of fear, we overdo things. I remember during COVID, if only we knew that what we needed for COVID was just our mask and hand hygiene. You see a lot of people in my center asking for the full hazmat suit. And I keep telling them that my experience with hazmat suit during Ebola is not palatable at all. The kind of heat that it generates. So people will not want to do anything unless they are totally covered out of fear. But if they are well convinced that, okay, this is the principle behind what you are doing, not just the principle of your fear, based on your fears or logic. We are talking about scientific proof. You can do this thing and then you are safe. So I want to believe that it is trust and fear, and probably to a lesser extent, not knowing about the principle behind it.
Okay, all right. Thank you so much for that beautiful response. I'm expecting that today's section be very engaging. We want to look at, this is a practical approach to healthcare waste management. So I'm expecting the questions. So to our participants today, what are your biggest challenges that you're facing in your facility in healthcare waste management? please do share those challenges with him so that he can prefer actionable solutions to you. Okay, so Dr. Ahmed is asking, my question is, how do you deal with the attitude of health workers that refuse to change concerning disposal of waste into appropriate segregated bins? In this regard, education is never ending point of focus. Okay, so would you want to make a comment?
Well, the person that asked the question have actually answered it.
Yes.
He actually said education is a never-ending point of focus. You don't probably what may be going through some people's mind is to penalize and then kind of punish people that don't do that. It is when you see them doing it that you can do that, but we are happy to see people doing it and then we are correcting them. And the attitude is, so if we start talking about the attitude of some people even believe that they are not supposed to trash the waste that they generated, that some people have to trash it for them. We continuously educate, right? And then probably out of ignorance or out of ego, some people still do what they are doing. We cannot do more than educate them until we get to a stage that if the management views it important, punitive measures, not necessarily strong capital punitive measures. Like if you are caught doing this, you'll be mandated to go for training with the IPC team on waste management. If you do it again, probably that is where they start. I'm just suggesting things off my head now.
Okay.
Okay, so we continue to engage people. That's just the issue.
So is it possible to include motivations so that people adhere? Like, are there possible ways to, motivate those who are doing so that others can also join?
Yes, we adopted motivations at a point in time whereby we are talking about collective motivation, where we say, okay, this unit is the most, is the cleanest unit of the month, and then the management award, monetary award for the unit.
Oh,
Let's say this month it is the male surgical ward that is the cleanest ward, and then you now see this competition among the units. That's when you now see the ward managers, our nurses, now struggling to make sure that, okay, we have to achieve this. Because during our monitoring, we see all of these things, we note it, and that's the basis for actually knowing which unit is the cleanest. That's the motivation. We cannot be motivating every single staff that is doing, anyway, we don't even know who is trashing or who is not trashing. So how do we motivate them unless we do that collectively?
Yeah.
All right.
Okay. I'm just off the top of my head, I'm wondering, are there facilities that have cameras to kind of monitor people secretly to see that they're adhering? Is it possible?
It's possible, but remember that we're in a low or medium income country.
Okay.
We have cameras in strategic places, not necessarily on the wards, because our wards are still somewhat open, and then you don't want to be having to record patients with their faces and all those things. But in other strategic areas, we have cameras. In some places, even if you have cameras about how you dump your, trash your waste, your clinical waste, to me, it's still not something you pursue. Okay, the cameras can actually see you as a defaulter, and then you'll be reported, and as such, go for more training.
Okay.
I don't think you can be sacked or probably be punished with suspension or whatever. No. What you would continue to do is voluntary compliance, engaging people, educating them, and then training. It is the recalcitrant one that, yes, you can now say, okay, this is what we do. We found you doing this the other time, we corrected you, we send you for training, and then you are still doing it again. Is it that you are doing it on purpose? You are endangering yourself, you are endangering other people we cannot afford to have you here. Probably post you to some other job that is different from clinical work. There are a lot of options that we can take depending on the peculiarity of our environment, our facility, and the likes.
Okay. Thank you so much. Thank you so much. Talking about limited resources. Okay, so Dr. Charles is asking, okay, saying that supply of color-coded nylons is a great challenge in his own hospital. I won't want to mention the hospital. So please, may I know how to ensure supplies, and can you link me up to one or two of your vendors? He's asking.
Okay, I don't know if you have my contact, you can contact me. Our environmental health units are in charge of this, and what we have in place is such that the linings are always available in the store. When it's reaching a critical point, they call for more supplies. The same thing with our stickers. It's our environmental unit that is taking care of that, so that we're never short of linings. So once the units, the clinical areas, the wards needs any lining, all they need to do is just call on the environmental department, and then it will be supplied within minutes. Okay. And if environmental unit is having issues with those things, together with the IPC team, we approach the management that this is what is happening. We pray that we don't run out of stock with the present state of the economy, but we'll be having it rosy such that once it's getting to a critical point in the store, alarm is raised, and then we call for supply. Right? You can contact me so that I can link you up with the environmental health people, so that they can tell you who has been supplying, and or probably the procurement department to know who has been supplying those linings.
Okay. Thank you. All right. Thank you so much. I remember some time ago, someone had also reached out to me to ask where they can get those colored buckets, the red, green, and the yellow. So I think that's something that the person you mentioned can also help with, the procurement unit.
Yes. In fact, the buckets, you can get it anywhere. You know, I told you our own challenge is that we would have loved that the buckets are colored red, yellow, black. But we couldn't do that because we go to suppliers to buy those buckets, and the manufacturers only produce buckets of different colors. For us to do that, that means we have to be in contact with the manufacturer direct. And I don't know how that would be possible, because the way government procurement system works is such that you give contracts out. Probably if the supplier now have to go to the manufacturer and say, these are the colors I want, it will delay, because the production will have to be tailored towards the demand of that supplier alone before it can be supplied. It's something that can be worked on, but we have not actually approached that area yet, which we may have to do, because it helps us in making sure that people identify. What we use to identify the bins are just the posters on top of the lids, as well as the lining inside. Okay.
All right. Thank you so much. Thank you. And to add to your response to Charles, I think that it's also very important for whoever that the storekeeper to, raise requisitions on time, monitor adequately to ensure that, they're not having very low supplies before you're making requests. So just ensure that these color-coded nylons are readily available. In some situations, you see people, they wait until they just have maybe very few number of it remaining before they start making requests. So that's what I may have to add to that.
Okay, Charles, I got your number. I'll contact you after the presentation.
Okay. So the next question is there any scientific reason why highly infectious waste should be autoclaved before it's kept in the red waste bin, pending when the waste managers come to pick it up?
Yes, it's part of your waste treatment. We are not developed to that extent here. To autoclave, you need a big autoclaving machine, especially for waste. We are not developed to that extent. And that is why what we do, the least we can do is to incinerate. That's the least we can do. Because there are other things you do as waste treatments that involve cost, machineries, and personnel, and as well as expertise. So the least that we can do in our center is to incinerate. Autoclaving is part of it, whereby you autoclave the waste to kill the germs around it before you bag and then dispose of. Other ways of treatment are actually disinfecting, chemical disinfection, and sometimes we use other methods. I can't remember the treatment methods now, but you can actually disinfect, you can autoclave. And that is the reason we're asking for a bigger incinerator. Bigger incinerator, we have a bigger chamber, we have operating temperature that is even close to 1000 degrees centigrade or more, so that we can kill the germs, kill the spores, make ashes, and then reduce the fumes, toxic fumes that comes out from burning plastics and every other thing. Those things can be reduced when you have a bigger chamber incinerator.
Okay, thank you so much for that beautiful response. So Dr. David Adeni is asking, in order to ensure sustainability, do you have systems in place to internally generate funds in support of your IPC program?
Well, IPC nationwide, IPC doesn't have a budget line. I think nationally they are trying to do that, to have IPC as a budget line. Here, what we do is all our IPC budgets are redistributed under different headings. Okay, under different headings. For instance, training, there is a budget line for training. So you include IPC training under that budget line. There is a budget line for other materials like personal protective equipment. You put your IPC under those ones. So we don't have a direct IPC budget. And if you ask me, I don't know how the management is getting those funds, but I can assure you that all these things, as of today, we are getting sustained supplies. All right.
Okay, thank you so much. Thank you so much for the response. Okay, Matron Ayorinde is saying that we can get the hospital equipment from Mushi. Yes, most of them are available. Okay, Mushi, Idumota, they sell hospital equipment. For those of us who might be interested in buying, this is where you can get them at good prices. Okay, nice presentation. I think engaging, participating, and continuous training will go a long way. Okay, that's a contribution from Aisha Gadu. All right. Someone else is asking, thank you, sir, for the presentation. Okay, I will get back to this later. Okay, so I remember during your presentation, you had mentioned evaluation. I wanted to know how often you do those rounds. Is it periodically, monthly, weekly?
No, our QI rounds, we do it 3 times in a week, Mondays, Wednesdays, and Fridays.
Okay.
Because it's a whole department. We don't have any other thing that we are doing in that department.
Oh, that's great.
So the other days we do it to service some IPC material, especially for hand hygiene, to go around to supply our sanitizers and our liquid soaps. But those 3 days are to monitor things in the hospital, not necessarily IPC, but other issues pertaining to quality improvements.
Okay, that's interesting. I don't know how many other facilities have enough resources to be able to do this as often as you do, but I'm hoping that.
Well, if you ask me, it's not as if you need uh, a lot of resources. It's the personnel that you have there that you make use of. For
Okay.
instance, in my department, what we have is just me, which I also double as the IPC focal person. And then I also do some clinical works in my family medicine department, train residents. Then we have our IPC nurse also in the department. Then we have other junior staff. We have a secretary who is an assistant director now and is getting promoted, who is supposed to oversee the secretariat. He also goes around with us if we need report writing and all those things. Then we have junior staff, 4, 5. That's all. The junior staff, some of them are the assistant health cadres, so that they are the ones that go around supplying the liquid soap, even washing of the wash and basins that are outside of the clinic and ward areas. They are the ones that do that every morning. Okay, so it may not take the management much. You just take from the existing personnel, and that's it. My IPC nurse is still doing some other things. This is something that we are still fighting over. Not fighting, the word is not fighting really, but that we are still discussing, such that, yes, it's still going to be under nursing department for administrative purposes, but let this person be relieved of nursing work and then face IPC. So that's another discussion entirely from what we have here, but it will help us in what we are doing.
Okay.
So your hospital may not need to do much.
Okay.
Just purposely create a department such that they focus on all these issues.
All right. Thank you. Thank you so much. We can't thank you enough for all of the. Okay. Okay. Somebody is asking, what about strategies to continue IPC in a sustainable way, especially in military health facilities? That's from Dr. Musa Hassan.
Well, I'm not familiar with the military facilities, but I have ideas because one of our colleagues or some of our colleagues are actually from military health facilities, and we share ideas. I know that the problem there is military, the control, the command or the command control, I don't know which language to use, comes from somewhere and then it percolates to the health facility. The person heading your health facility may not able to talk to the person that is higher the rank that he needs to talk to. And then if the person say no, it is no. To even address such things, you may have to use external people. In this case, you may use the Nigeria Center for Disease Prevention and Control, the NCDC people, the IPC units of that agency to help you talk to your military leaders in that facility, that this is what we do for IPC and this is how we can sustain it. And then just solicit, do advocacy drive. They will do advocacy drive to your facility and even beyond your facility. They have the capacity to talk to people in defense, in army, in navy, the organs over there. And then the thing will percolate to all the health centers. I'm just saying this from my little knowledge. I don't know much about it, but I guess you understand what I'm trying to say. I know it's a challenge in military health facilities. I know. Yes.
Okay. So that means engagement should be at the top too.
Yeah, so the engagement has to be from the top as well.
Okay. Thank you so much for that beautiful response. I don't know if we have more questions. We love each and every one of us to look at the link in the box, in the chat, and then fill the feedback form. We'd love to know how much you want us to improve on the program. Your comments is really, really expected and will be appreciated. Thank you, Dr. Usman Olagoke. We have here our certificate of recognition. We recognize your invaluable contribution on this topic, sharing the experiences, from Ebute, Metta, FMC. Thank you so much. It's a wonderful lecture.
Yeah, you're welcome. It's a privilege for me to be here, so I don't take it for granted. I'm thanking everyone that have made it possible, as well as the participants that have taken time out to listen to this program. Thank you very much.
Thank you, sir. Okay, somebody just added, if we understand your answer, continuity of IPC depends on leadership commitment, sustained training, availability of resources, regular monitoring, and fostering a culture of safety at all times. Very beautiful. This is like a summary.
Yes.
Thank
Yes.
you for this contribution.
Thank you,
sir.
Mr. Musa.
Yes. Thank you so much. So I'll give you a little time for us to fill the feedback forms. Please do well to give us feedback. And then somebody is asking, are we going to get the recorded section? Definitely you're getting the recorded section and also the slides. So for those of us who have used the link that is in the chat box, I might have to share that link again. If you filled your emails, if you have your emails, you get regular communications from NSIC. You don't have to fill the form again. Just be rest assured that you're getting the recorded session from us. But those of us who are joining us for the first time, please use this link that I have reshared again to give us your name, your email. It gives you the opportunity to be on our database to get regular communications from us. So once we have that email, be rest assured that you're getting the recorded section and the slide. I don't know if we have any more questions. So I'm going to give a little time for us to fill the feedback form and also make the feedback form and also to share our emails. And while we're doing that, I would like to, some of us are joining for the first time and they might be wondering, they might want to have more information about what we're doing here today. So this is NSIC, Nigerian Society for Infection Control. We are committed to fostering excellence in IPC through collaborations, education, and also advocacy, and ensuring that there is the improved quality of healthcare delivery and also safety of patients and healthcare workers in Nigeria. We have our sections every last Thursday of the month. It happens monthly. We bring in seasoned speakers, experienced with their wealth of knowledge to take on topics here. And also some of the other things that we do is our spotlight section where people come share, do facility experience, yes, improvements in their facilities. So the interesting thing is that you will definitely learn something that you will take home with you to take back to your facility. For those who might want to become a member of our society, you can send an email to us, nsicnigeria@gmail.com. Maybe going forward, I may have to do a little presentation. For those who might just be asking, so what does it cost to become a member of NSIC? Now the advantage of being a member of NSIC is that you also get the opportunity to become a member of ICANN. ICANN is Infection Control Africa Network. So it might be difficult to become a member of ICANN without being a member of a local society like ours, that's NSIC, and it gives you room to get a subsidized payment. Now, instead of registering to become a member of ICANN with $20, you're paying just as low as $5, and that $5 is inclusive in your membership fee. That is 20,000 Naira only. So if you want to get more information on how you can become a member, please do reach out to us via email, nsicnigeria@gmail.com. If you have any further questions, even for the speaker, send across to us. We'll definitely share with him and you get feedback from us. So at this point, okay, somebody said, sorry, ma, the network couldn't make me access the feedback form. Okay, maybe I have to reshare that. You do not have to put your email here. Just use this link, and so you're on the database. You get, even when you're unable to join, we understand that healthcare workers are very busy, very, very busy people. So some of us might not be able to participate in some of our sections, but if you're on our database, you surely get the recorded section, any of the sections that you miss, and also get regular information from us. Okay, so yeah, okay, so I have dropped the email nsicnigeria@gmail.com. Reach out to us with your questions and every other information that you need. So thank you very much to everyone, most especially to our speaker. Thank you for everyone who has contributed and made this section an engaging one, especially also those of us who joined earlier. I understand that some of us might be having network issues. That's fine. We'll get the recorded section. Please don't put your email on the chat box. Please just use the link to drop your email so that even in future you will shortly get communications from us. I have reshared that email again. I'm sorry, I've reshared the link again. Please use this link to share your email with us. That way you're on our database and you get regular communications from NSIC. Thank you very much to everyone. Thank you once again, Dr. Usman. Before I forget yet, so next month, we're going to be having a topic on re-emerging diseases, particularly on diphtheria. And one of the things that we want to start doing now is give people the opportunity to share case studies from their facilities. So now that we'll be looking at diphtheria, if there's an outbreak in your facility, if there is a challenge, if there's particular questions, or just a case study of a patient who is presenting with something that you need more information from fellow IPC practitioners or doctors that are here, you can reach out to us so that we make you part of our presenters for next Sunday. You want to share something very interesting with the rest of us about a particular case in your facility. So please reach out to us. Reach out to us. Yes, thank you for, okay, it's an interesting section. Yes, and to make it more engaging, we want participants to do more. So from your various facilities, I might not be in your state or your facility to know what's going on there, but some of us are interested to know more and also to get more information, insights from how stuffs are happening over there. It's knowledge sharing. So I look forward to having some of those contributions. Okay, someone is saying, what is the integrate IPC into combat medical? I'm not sure I understand that. What about portable IPC kits for field operations? Okay, is the question for the speaker? Portable IPC kits for field operations. What is the integrate IPC into? Okay, okay. Are you saying how do we integrate IPC into combat medical? Okay, collaborative way. Okay.
I think the person is talking about the military
Okay.
health facility. You know,
Oh,
during combat, injured soldiers and the likes.
oh, I get.
During war, you have a tent that you create to quickly apply first aid or to take care of injured soldiers before you transport them to a bigger facility.
Oh,
Yes, wherever you administer health care, IPC must be involved. And I know that in war situation where you create tents, temporary tents for injured soldiers, IPC infrastructure should be there. And I'm sure you'll not be using your bare hand to be doing wound dressing or wound suturing. Part of IPC structure that should be there is the use of gloves. You have your waste management, your hand hygiene procedure, and every other thing. I think it should be there. if you're an IPC professional, you should be able to draw up an IPC plan for that facility, whether it is temporary or permanent. You should be able to draw up such things. And we are still talking about everything. Anywhere healthcare is being assessed, there must be IPC practices. At least the standard precautions, some of the standard precautions, you know what our standard precautions are. At least waste care management is one of the standard precautions, hand hygiene, PPEs, linen healthcare facility. That's just all. Whether you are operating as a military healthcare facility or civilian healthcare facility, IPC is the same everywhere in the world. Right.
Okay, thank you so much, Dr. Olagoke. Thank you for that beautiful response. Okay, Mr. Charles. Okay, yes, I have taken note of your number, Mr. Charles. I have your number now. Okay, so I also included in the chat the official line on LSIC in case you may want to call. So that's the number there, 08024304016. So now, part of the things that we do, apart from sharing email communications, sometimes we send notifications on WhatsApp. For some of us, I understand that not a lot of people go to their emails regularly. So via WhatsApp, for some of us who have been with us for a long time, you get notifications from us prior to our sections. So at this point, so that's the number there, 08024304016. All right. So at this point, we'll have to draw the curtains. Thank you once again to every one of us who took out time to be part of the section. Someone said
Sorry,
IPC. Okay.
sorry.
All right.
About the WhatsApp group, how can one join the WhatsApp group?
Okay, so it's not yet a WhatsApp group. It's just our WhatsApp number. So initially we had considered creating a WhatsApp group, but sometimes there are some people who don't like WhatsApp groups. But if a lot of people are saying we should create a WhatsApp group, we might have to go ahead with that. Some people, I hear people tell me they are in a lot of groups. So we usually reach out to people individually via WhatsApp, share notifications via WhatsApp. But if
No, I feel WhatsApp group will make a lot of sense
okay.
because it will I'm seeing it to bring a lot of persons very close.
All right. Okay, that's great.
That,
So,
that's just my own idea.
all right, this is the point is taken. We will share that with the management, and then we'll surely do that if it's approved. Thank you so much for that contribution. Thank you so much, Mr. Augustine. So someone said IPC was very active during COVID pandemic, but a lot has to be done to keep it going. I suggest in adding IPC in yearly budget. Sadly, a lot of us is until they announce an outbreak. That's when you see people, start doing the necessary things. But once, the scare has gone, a lot of people let down their guards, and it's not good. As far as we know, diseases, they don't share, how would I put it? They don't give you notification ahead of time that I'm coming, so that means that everybody has to be at guard at all times. And like you said, yes, it's very important that IPC is included in yearly budgets. Okay, so someone else is saying, please open the WhatsApp group. It's better. Okay, that's great. We're taking note of that and we'll work towards that. Thank you very much to everyone. Thank you for the webinar, quite interesting. Yes, I agree with you. So at this point, we draw the curtains. Thank you for being part of this interesting section today. Special thanks to FMC, Ebute, Metta, IPC committee, IPC team, and also the head of IPC in Ebute, Metta. I want to acknowledge one thing. If the management did not give them the necessary support, I'm not sure that they would have been able to achieve all of the things that, this fits. It means that all hands must be on deck. Everyone has to play their parts to ensure that some of these things are put into, these ideas are put into actionable motions. So thank you to everyone. I really appreciate the time that you have taken out of your very busy schedule to be part of this section. And at this point, I want to say goodbye.